Good morning, everyone. I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. Today, I wanted to discuss history taking in obstetrics. Of course, all of us know that the items important to reach the diagnosis, including history taking, examination, and investigations. So, today, we wanna to know about history taking in obstetrics. So we wanna to know the opening of the consultation, the personal history, the complaint of the patient, menstrual history, obstetric history, past history, family history, present history, and lastly, how to do risk assessment for each woman. Okay, first introduce yourself, including your name and your role. So you said, I'm a medical student, I'm a doctor, I'm a registrar, and so on. So first introduce yourself and tell the patient about your position. Explain the need to take history and gain consent. Oral consent is quite enough. Respect confidentiality and dignity is very important. You should have skills to manage sensitive topics. Especially challenge when you meet certain patients, like silent patient, like talkative, angry, or depressed patients. Chaperone could be present, maybe her sister, her husband, her friend. What about the personal history? First, you should know the name of the patient for registration and to call her by her name, and don't forget to say Mrs. before her name for inspection, and her name to be familiar with her. Age of the patient is important because certain diseases occur more in young, like severe preeclampsia occur in pregnant patient, prime gravida at the age of 18 years old. Also, preterm labor is commoner in very young pregnant lady at the age of 18 or less. So, certain age is a risk factor for certain problems. Occupation. Yes, occupation is important for the pregnant lady. Suppose the physician working in radiodiagnosis or radiotherapy exposed to radiation. So we know that radiation is teratogenic. So occupation is very important to be known by the doctor. So to ask the patient to avoid risks. Residence. Residence, you know many things from residence. The social factors, the ability of the patient to be uh, coming for antenatal care, her financial position. So it is very important to know the residence of the patient and if she is near to any hospital or place for antenatal care or not. So it is very important. Duration of marriage, yes, you should know the duration of marriage. Of course, if the patient has infertility or an ability to conceive for more than 1 year, you will know from that, from the duration of the marriage. Number of living children is very important because you wanted to know how many living children. Suppose the patient has the bad obstetric history and the previous intrauterine fetal death once or twice. So you suppose she has two children while she has no living children. So you should know the number of living children during history. Special habits. Yes, very important to ask here about smoking or drug addicts or alcohol intake. So it is very important because it has hazards on pregnancy. Alcoholic fetal syndrome is some of the congenital malformation occur in pregnant lady taking alcohol. Also, smoking may cause IGR or small for gestational age baby and low birth weight. So it is very important to know if the patient has a special habit or not. What about the complaint of the patient? The complaint should be in patient own words. Don't use scientific term under the heading of complaint. So you start to ask the patient what's brought you in today or what is your symptoms. Then the complaint may be cessation of menstruation for 2 months, 3 months, 4 months, and so on. Or she came for antenatal care or any other complaint like diabetes. She knows that she has a diabetes or because she is cardiac patient or she has thyroid problem. Or she may came for confinement, means because she wanted to be delivered, because she is now full term and asking about delivery. So if we have more than one complaint, we can arrange them chronologically, okay? Or we can arrange them according to the importance of each complaint. Some examples for obstetric complaints like vaginal bleeding or discharge, nausea and vomiting, frequency and or painful micturition, headache, flaring of vision, swelling of lower limbs, abdominal pain. So what about the menstrual history? Menarche. Menarche is the first day of the first menstruation in the woman's life. Rhythm of the cycle may be regular or irregular. According to what? According to variation between the cycle, the length of the cycle, 2 days plus or minus, considered regular if within 2 days plus or minus the cycle length. This is the old definition, but the recent definition said it is regular cycle if variation of the menstrual cycle length measured over 12 months less than 20 days. This is called regular. But if variation more than 20 days, it is irregular. So we calculate. Suppose the menstrual cycle is, this menstrual cycle is 30 days. The previous length of the cycle was 28 days. So there is variation in 2 days. So we calculate this variation over the 12 months. And the sum of these days, if less than 20 days, so we said this is a regular cycle. So this rhythm is regular of the menstrual cycle. But if this sum of the days over the 12 months in the variation more than 20 days, we said irregular rhythm. What about the cycle length? Cycle length measured from the first day of the cycle to the first day of the next cycle. This is the cycle length. The normal cycle length simply ranges from 21 to 35 days. I mean 28 days plus or minus 7 days. So range between 21 to 35. And this is the old definition of the cycle length. But FIGO in 2011 make another range. They supposed to be range from 24 to 38 days. This is the normal cycle length as mentioned by FIGO in 2011. Between 24 to 38. What about the duration of the menstrual flow? Normally it is between 2 to 8 days, and this is in all definition, while in FIGO 2011 they said the range should be between 4 to 8 days. The character of flow of the menstrual flow is very important to mention the amount, the color, the odor. So it is very important to mention the character of the flow. If associated with blood clots, if it is associated with normal odor or offensive odor, if the menstrual flow black or bright red in color, so it is very important to mention the character. Is there any dysmenorrhea? Dysmenorrhea means painful menstruation that interfere with daily activity of the woman. So if it is positive or negative should be mentioned. Again, in menstrual history, the intermenstrual period. This period between the first day of the next flow and last day of the current flow. This period we ask about pain, bleeding, and discharge in this time. So this free period, free from menstrual flow period, or what is called intermenstrual period, we ask the patient about any discharge, any bleeding, any pain in this time. For the use of contraception, if the patient was using contraception within 6 months, we mention it in the menstrual history. If it is an older use of contraception beyond 6 months, we mention it in post history. The method of contraception should be mentioned, like IUD, like mini pills, like combined oral pills, like barrier contraception, whatever should be mentioned in the menstrual history if it was used recently within 6 months. Of course, she is pregnant now and she stopped the contraception, but we're asking about the history, the previous history. Lastly, in the menstrual history, we should know the first day of last menstrual period. And from the first day of last menstrual period, we can calculate the expected date of delivery. So this is the last menstrual period, and this is the expected date delivery. According to Nigel's rule, we will calculate it. And to said the last menstruation was normal and the date is certain, should carry certain criteria. The previous 3 cycles were normal, yes. Last menstrual flow was normal as regard the duration and characters. No recent intake of hormones in the form of hormonal combined oral pills or any other hormonal treatment in the previous 3 months. So if these 3 criteria is present, so we said this date is certain and this last normal menstruation can be used for calculation of the gestational age properly. What about the calculation of the expected date of delivery? We use Nigel's rule. We add 9 months and 7 days to last menstrual period. For example, if the last menstrual period was August 4, 2019. So what is the expected date? We add 7 days over 4, it will be 11. Okay, then we add 9 months over August, so over 8 here, so it will be May. So the end result will be 11th of May 2020. This is the expected date of delivery. We add 7 days and 9 months. 7 days and 9 months to reach the expected date of delivery. Okay, what about the menstrual delivery interval? It is about 28 days or 40 weeks or 9 calendar months plus 7 days or 10 lunar months. So this is the full term, 40 weeks or 28 days or 9 months plus 7 days or 10 lunar months, as you see in the picture also. Conception delivery interval, to know the duration of pregnancy. Used in cases of IVF or one single intercourse happened in this time, or in cases with rape. 266 days, this is the duration, or 38 weeks. So this is called conception delivery interval. Okay, let us go to the next item, which is obstetric history. We wanted to know the gravidity, the parity, the deliveries, whatever normal or abnormal, the miscarriage or abortion, the previous pregnancies, previous breastfeeding. Start with gravidity. It means the number of times a woman has been pregnant, regardless of the outcome. So it is just number of all pregnancies, whatever normal or abnormal or complicated or not. Parity is the number of deliveries after completed 28 gestational weeks, whether normal or abnormal. And you should know that medical legal viability is 20 weeks in USA, 24 weeks in UK, and 28 weeks in Egypt. So some use 28 weeks as a medical legal viability as in Egypt. Others in USA use 20 weeks, and in UK they are using 24 weeks. Okay, the third item in obstetric history is the deliveries. I wanted to know how many full-term normal deliveries and how many abnormal deliveries and the details in each one. And lastly, the date of last delivery. Let us speak in more details. For full-term normal delivery, to say normal labor should be single baby, like this one in the picture, living, presented by vertex, delivered through the normal natural birth canal within a reasonable time, more than 3 hours and less than 24 hours, without any complication to the mother or to the fetus, without aid. Okay, so this is called normal labor. Single, viable, mature. Mature fetus means more than 37 weeks gestational age. Delivered through natural birth canal within a reasonable time, without aid, without any complication to the mother or to the fetus. So what about the abnormal deliveries? maybe in the form of multiple pregnancy, like twins, like this picture, twins, induced labor and instrumental deliveries. You see here instrumental deliveries. This is vacuum aspiration or ventouse, or this uh, 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 ventouse suction, or or forceps instrumental delivery. So this is called instrumental delivery. This is abnormal delivery. Preterm birth between 28 and 37 weeks gestational age, or post-term more than 42 weeks. Stillbirth means delivery of dead fetus. Non-vertex presentation, abnormal or malpresentation, like breech, like in this picture, this is breech presentation. We cannot say normal delivery in case of breech, so it is abnormal delivery, breech presentation. Also, others like face presentation, cesarean section, prolonged labor more than 24 hours, or precipitate labor if labor happen within less than 3 hours. It's called precipitate labor. Lastly, maternal or fetal complication. This is called abnormal delivery. So, in this item, we said for deliveries, we should know the normal and the abnormal one. Then we will go to miscarriage or abortion. Number of abortions should be known. If more than two, is it sequential or not? Recurrent one and sequential. Onset spontaneous or induced. The gestational age should be known for each pregnancy. And termination, was it spontaneous or medical or surgical? And the date of last abortion. Like in this picture, this is a abortus of 11 weeks gestation. What about previous pregnancies? Was it normal or complicated? Complication may be in the form of puerperal sepsis, in the form of preeclampsia, premature rupture of membrane, or diabetes mellitus. So all this is very important. What about the puerperia? The previous puerperia were normal or not? For example, for abnormal puerperia may be postpartum hemorrhage, or deep venous thrombosis, or puerperal sepsis. Okay, what about the gravidity? After I finish the obstetric history, the gravidity, puberty, and abortions. In this red box, here G for gravidity. So when I say G2, the patient was pregnant twice. Parity, like P. When I said P1, I mean she delivered once before. Abortions, A for abortion. If I said A1, so the patient had one abortion before. So I can write G2, P1, A1. So you will understand that the patient was pregnant twice, she was delivered once, and she has one abortion. Okay? Another system to present the obstetric history is 5-digit system, like this one. To describe the obstetric history, we use G for gravidity, T for term birth, B for premature birth, A for abortions, L for living children. So when I said G4, T1, B1, A2, L2, I means there were 4 pregnancies before, 1 term birth, 1 premature birth, 2 abortions, and 2 living children. So you can use this system or the other system, any one of them is correct. Okay, what about the past history? We wanted to know past history of any medical disorders or drug and allergy history, immunization history, and we should check the patient is currently up to date with their vaccination. Any old or recent vaccination is very important to be known. Ask about previous mental health diagnosis, very important to know about it during pregnancy. Surgical operation, whether general surgery or gynecologic surgery, general surgery like appendectomy, cholecystectomy, and so on. Gynecologic surgery like repair of prolapse is very important and may affect my decision about delivery, method of delivery. Is it by cesarean or vaginal? Myomectomy, I means excision of fibroid from the uterus. It's called myomectomy. It may leave a weak scar, so I should know if the patient did before myomectomy for the risk of rupture uterus during labor. What about the family history? I need to know the consanguinity, if there is family history of multiple pregnancy, any familial disease, whatever hereditary or non-hereditary. Hereditary like cystic fibrosis, like sickle cell disease, like type 2 diabetes. Remember that first degree relative with diabetes increases risk of developing gestational diabetes for the pregnant woman. Non-hereditary but familial like rheumatic heart disease, people living in the same condition, same environment, are exposed more to certain disease like rheumatic heart disease like TB and so on. So yes, the disease run in family but not hereditary. Preeclampsia, maternal mother or sister increase risk of developing preeclampsia, the pregnant woman. Similar condition in the family, like Down syndrome, is very important to ask about. What about present history? We should start the present history with the condition started with secondary amenorrhea with the first day of last menstrual period and mention it, the date of last menstrual period. This was followed by symptoms suggestive of early pregnancy in the form of nausea, vomiting, sleepiness, fatigability, craving to certain types of food. Then pregnancy was confirmed either by pregnancy test or ultrasound and write the date of each test. Then ask the patient about quickening, which is the first perception of the fetal movement by the pregnant mother. It is different between multiparous or primigravida. Multiparous because she is more experienced, she feel the fetal movement earlier than the primigravida. So in multiparous, it occurs between 16 to 18 weeks gestational age, while in primigravida occur between 18 to 20 weeks gestational age. Continuation of our present history, then do analysis of the complaint, ask about the onset of the problem, the course, the duration, the severity, what is precipitating for the condition, or what is the relieving factors. All this in analysis of her complaint. Suppose she has a bleeding or pain, we will ask about all these items. Any investigation done and the drug therapy given in this current pregnancy, you should ask the patient. What about the state of the fetal movement? Is it okay? You can feel the fetal movement freely and day and night? Any symptoms suggesting approaching labor, like difficulty in walking, like frequency of micturition, like watery vaginal discharge, okay, like pelvic heaviness, any symptom suggesting urinary or GIT problems, you should mention it. Okay, I wanted to concentrate on key symptoms you should ask about. Nausea and vomiting, because there is a problem called the hyperemesis gravidarum, severe vomiting affecting general condition. Reduce the fetal movement, because it may be a sign of fetal distress. Vaginal bleeding, because it is very important, maybe antepartum hemorrhage due to placenta previa or abruption placenta, or due to local cervical causes. Abdominal pain, which may be due to urinary tract infection or placental abruption or constipation, or pelvic girdle pain or labor pain. Vaginal discharge may be abnormal vaginal discharge due to infection, or watery discharge due to spontaneous rupture of membranes. Headache and visual disturbance, the gastric pain, all these are symptoms of preeclampsia, especially the severe one or imminent one. Pruritus, which may be a sign of obstetric cholestasis. Then, closing the consultation, summarize the history and ask the patient if there is anything else she would like to add. So it's very important to ask her about that. Then thank the patient very much for cooperation. Lastly, after we finish the history taking in obstetric case, we should have risk assessment. So our patient fall in one of these three categories. She is in low risk one, or moderate risk, or high risk. Low risk one, no identifiable for obstetric medical or surgical complication in this woman. So can be managed in the community by community midwives. Can be delivered in midwife-led units. While in the moderate risk cases, non-life-threatening obstetric medical or surgical complications present. Can be jointly managed by community midwives and obstetricians, and should be delivered in obstetric-led units. The last group, the high-risk one. If your patients fall in this high-risk group in risk assessment, so there is any life-threatening obstetric, medical, or surgical complication, should be managed by a subspecialist feto-maternal obstetrician, and should be admitted and delivered at high-risk obstetrics unit. Okay, so it is very important to categorize your patient low risk or moderate risk or high risk after you finish your history taking. So, to summarize our lecture, we said that history taking in obstetrics include personal history for the pregnant lady and for her husband also is important, like name, age, duration of marriage, occupation, residence, number of living children, and any special habits. Then we shifted to complaint and we said should be inpatient onwards. And we said in pregnant lady usually there is cessation of menstruation and there is many other complaints maybe in obstetrics like bleeding, like discharge, like pruritus, like headache, blurring of vision, epigastric pain, like watery discharge with premature rupture of membrane, like cessation of the fetal movement or decrease fetal movement like abdominal pain. So all these are complaints and should be written in patient own words. Menstrual history, and we said we wanted to know about the menarche and the menstrual cycle length and characters, is it regular or not, and its length and duration of the menstrual flow and its character, and if there is dysmenorrhea or not, intermenstrual period free of pain, bleeding, or discharge or not, and last menstrual period, and if there is a history of using contraception or not. From last menstrual period, we can calculate the expected date according to Nigel's rule, and we said the duration of pregnancy is 9 months plus 7 days or 10 lunar months. Okay. Obstetric history include the gravidity, the puberty, the deliveries, the normal deliveries and abnormal deliveries, and last delivery is very important. Then we shift to abortions or miscarriage, the number, the duration of pregnancy, the onset, spontaneous or induced, and the method of termination, spontaneous or medical or surgical one, and the last abortion. Then previous pregnancies were complicated or not by DVT, by by DVT or preeclampsia or bleeding, and previous puerperia, was that normal or complicated like DVT, Berber sepsis, and so on. This is all this in obstetric history. Then we shift to past history, and we said any past history of medical or surgical operation or medical disease, past history of immunization, past history of mental health diagnosis, past history of drug allergy or any therapy. Then we shifted to family history, and we said any consanguinity or positive consanguinity or not, history of multiple pregnancy, history of familial hereditary or non-hereditary disease, history of similar condition like Down syndrome. Then we shift to present history, and we mentioned the story of the pregnancy starting from the early pregnancy symptoms, then the confirmation of pregnancy with pregnancy test and ultrasound, and the quickening time, the first perception of the fetal movement, which date, then any complication during the pregnancy and the analysis of any problem happens or complications happen during pregnancy like pain, bleeding, or discharge. Then symptoms of approaching labor, we asked about it. Then lastly, GIT or urinary symptoms. And we said there is very important symptoms denoting certain problems like severe epigastric pain with headache and the blurring of vision may shift our attention toward preeclampsia. Pruritus may shift our attention towards cholestasis. So it is very important to know these signs also and symptoms. Also, decreased fetal movement may denote fetal distress, and this is very important. Dysuria and the frequency of micturition may denote there is UTI. So this is alarming symptoms and it should be known very well. Lastly, after the present history, we categorize our patient after the end of all these data from history into three categories: mild risk, moderate risk, or high risk. And we said high risk should be delivered by a consultant with subspecialty like fetal-maternal, and of course in a well-equipped hospital. Moderate risk should be delivered in obstetrician-led unit. Mild risk may be delivered in midwife-led unit. And this is the last slide. This is a question. Please read it and try to answer it. A pregnant woman, 35 weeks, and had obstetric history of 2 miscarriages, 1 ectopic pregnancy and 1 preterm labor. What is the gravidity and the birth in this case? Fifth gravida primipara, third gravida primipara, sixth gravida second para, fourth gravida primipara, fifth gravida second para. Please choose the most correct answer. This is my last slide. I hope this lecture was clear. Thank you. I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University.